Chapter 3, Implementation Research Outcomes. Hi, my name is Vivian Go, and I'm an associate professor in the Department of Health Behavior at the Gilling School of Global Public Health at the University of North Carolina in Chapel Hill. Today, we're going to talk about how to measure implementation research outcomes. In Chapter 1, Dr. Alonge discussed the differences between intervention efficacy, intervention effectiveness, and implementation effectiveness. Then in Chapter 2, Dr. Alonge introduced 6 examples of field studies conducted in Africa on infectious diseases of poverty and the implementation research outcomes that each of these studies utilized. In Chapter 3, I'll be talking about how to measure implementation research outcomes using these same 6 examples. This chapter specifically will be divided into 2 sections. In Section 1, we will discuss examples of how implementation research outcomes have been defined and operationalized in implementation research focused on infectious diseases of poverty in the field. In Section 2, we will describe data sources, in other words, from whom we will collect data from, and data collection approaches, in other words, what methods we will use to collect data to support implementation research outcomes. Let's start by taking a little quiz to gauge your awareness of these issues. This is just for you to get a sense of what you know and what you don't know, but can learn from this chapter. I'm going to read 4 statements. Please take a moment to write 1 through 4 on a piece of paper. After each statement I read, mark if you think the statement is true or false on the paper next to the statement number. At the end of Chapter 3, I'll revisit the statements and go over why each of them is either true or false. Statement number 1. True or false? Data for measuring implementation research outcomes are often collected across multiple socio-ecological levels. By socio-ecological levels, I mean individual level, community level, organizational level, etc. Statement number 2, true or false? Data on implementation research outcomes can be collected using both qualitative and quantitative methods. Statement number 3, true or false? Administrative data are useful sources of information for measuring implementation research outcomes, such as cost and fidelity. By administrative data, we mean data that is already being collected by the organization or program. Statement number 4, true or false? Measurement of implementation research can often involve scale development. You can set aside your paper now, and we'll go back and revisit these statements and the correct answers at the end of this chapter. In the meantime, let's go over these concepts in the next 2 sections. Let's go back now to the 6 studies that Dr. Alonge presented in Chapter 2 of this module. I'm going to use these 6 studies as examples of how implementation research outcomes have been defined for a specific disease in a specific context. First, let's look at the example of the study entitled Community-Directed Intervention Strategies for the Control of Onchocerciasis with Ivermectin. As we mentioned in Module 2, the goal of this study was to assess if a community-directed intervention approach improved treatment coverage in onchocerciasis-affected communities. The implementation research outcomes in this study were coverage and cost. Coverage was defined as the number of persons treated with ivermectin per total population within a community health worker's kinship zone in 1 year. In other words, the total number of people treated among those who should have received it. Cost was defined as the cost of training, which included allowances for trainers, transport and food for trainees, and training materials, divided by the total number of community health workers and supervisors that were trained in 1 year. In the study conducted by Akugan and colleagues in Nigeria among nomadic Fulani communities to manage malaria, the implementation research outcomes were coverage and acceptability. As we mentioned in Module 2, the goal of this study was to improve uptake of insecticide-treated nets and prompt treatment of malaria among children who are under 5. Coverage in the study was defined as the proportion of children under 5 with a fever who received anti-malarial treatment, as well as the proportion of individuals under insecticide-treated nets per 2 nomadic cycles within a predefined nomadic group. Acceptability in this study was defined as general satisfaction with community-directed intervention strategy and the two evidence-based interventions consisting of treated nets and malaria treatment, as well as the demand for evidence-based interventions in the community. In the study conducted by Akuwango, artemisinin-based combination therapy distributed through a community-based distributor in rural areas in Ghana, Burkina Faso, Ethiopia, and Malawi was evaluated. Specifically, community medicine distributors were trained to educate caregivers, diagnose and treat malaria cases in under 5-year-old children. The implementation outcomes of the study were fidelity, coverage, and feasibility. Fidelity here was defined as services delivered by community medicine distributors as planned, which was measured as the proportion of febrile illnesses that was treated with artemisinin-based combination therapy, promptness of treatment, and correct dosage and duration. Coverage was defined as the proportion of children who are under 5 who presented to the community medicine distributors that were treated within 24 hours of onset in the 2 weeks prior to the survey in a predefined area. Feasibility was operationalized as the community medicine distributors' self-reported ability to recognize and promptly treat malaria cases and caregivers' acceptability of these services provided by the community medicine distributors. In the study conducted by Oki Bernard and colleagues in Nigeria, Togo, and Cameroon, researchers studied the involvement of community-directed distributors of ivermectin for onchocerciasis control and other health-related activities. Specifically, the researchers addressed or assessed if involvement in additional activities such as EPI, water and sanitation, and community development projects detracted from their effectiveness in delivering ivermectin. Feasibility and coverage were measured as the two primary implementation outcomes. Feasibility was measured as attitude and performance of CDDs involved in other public health activities. In this case, performance was measured as coverage rates for ivermectin treatment. Coverage was measured as the proportion of the population who received ivermectin treatment in the communities from which the community-directed distributor were selected. In the study, early treatment of childhood fevers with prepackaged antimalarial drugs in the home, Sarima and colleagues evaluated the impact of using prepackaged antimalarial drugs by mothers at home on the progression of disease in children from uncomplicated fevers to severe malaria. Fidelity was the only implementation outcome assessed, and it was operationalized specifically by looking at the proportion of children 6 years and under who had uncomplicated malaria that was treated as planned. Treated as planned here was defined as being promptly treated with prepackaged antimalarial drugs with correct age-specific dose and duration in the 4 weeks prior to the assessment survey. In the last example, Akugun and colleagues assessed strategies for community-directed treatment of onchocerciasis with ivermectin in Nigeria. The study evaluated fidelity, coverage, cost, and feasibility as its implementation research outcomes. Fidelity in this study was measured as appropriate adherence to the treatment regimen, correct dosage and treatment frequency, and the correct management of adverse reactions to medication. Coverage was measured as the total number of people treated out of the total population after 2 cycles of treatment. Feasibility was operationalized as the acceptability of a range of community-directed ivermectin approaches and the cost and coverage under different approaches. And finally, cost was measured as all costs that the villages spent in delivering ivermectin. You'll notice that although there are similarities in diseases such as malaria and onchocerciasis in these examples, that both selection of implementation outcomes and the way that they were operationalized were tailored to the specific goals and contexts of the interventions and the studies. So, for example, in the study conducted by Akugun and colleagues in Nigeria among nomadic Fulani communities to manage malaria, the implementation research outcomes or coverage and acceptability. As you may remember, the goal in this study was to improve the uptake of insecticide-treated nets and prompt treatment of malaria among children under 5. In the study conducted by Akuwango, artemisinin-based combination therapy distributed through a community medicine distributor in rural areas in Ghana, Burkina Faso, Ethiopia, and Malawi was evaluated. The implementation outcomes of this study were fidelity, coverage, and feasibility. So you can see there were differences in implementation outcomes selected based on the goals of the intervention. And although both studies looked at coverage as an outcome, the operationalization was a little different. Coverage in the study by Akugun and colleagues was defined as the proportion of children under 5 with a fever who received anti-malarial treatment, as well as the proportion of individuals under insecticide-treated nets per 2 nomadic movement cycles within a predefined nomadic group. Coverage in the Akuwanga study was defined as a proportion of children who are under 5 who presented to the community medicine distributors that were treated within 24 hours of onset in the 2 weeks prior to the survey in a predefined area. So you see that there are similarities in the operational definitions of coverage. So both consider appropriate malarial treatment for children under 5. But one denominator is all children with a fever, whereas another denominator is just among those who presented to a community medicine distributor. And one also considers insecticide-treated nets. These are due to the differences in the evidence-based interventions being tested or being scaled up. In addition, the timeframes are different. One considers it per nomadic movement cycles, while the other considers it within 2 weeks prior to the survey, reflecting the different populations under study. That is why we say implementation research outcomes are heuristically defined. Now that we've talked about how different implementation outcomes can be operationalized in the field, we're going to talk about how data on implementation research outcomes are collected. Implementation research outcomes can be collected at different levels and through different data collection approaches. I want to emphasize that implementation studies typically use mixed quantitative-qualitative designs, identifying factors that impact uptake across multiple levels, including patient, provider, clinic, facility, organization, and often the broader community and policy environments. Accordingly, implementation science requires the involvement of transdisciplinary research teams, as we had mentioned in Module 1 of this course. Common quantitative measures include structured surveys that assess, for example, organizational context, provider attitudes and behaviors, patient receptivity to change, or household access to provider services. Administrative data are often utilized either in focal target populations or at the bottom systems levels to characterize, for example, baseline and change in rates of utilization of particular practices. Common qualitative data collection methods include semi-structured interviews with patients, providers, or other stakeholders, focus groups, direct observation of clinical processes, and document review. One final note, implementation research outcomes are by nature latent variables. That is to say that these variables are often not directly observable, but are rather inferred from other variables that are observed, and may require scale development. For example, you cannot directly observe acceptability, but rather can combine a series of questions that together infer acceptability. Let's look now at each of the 9 implementation research outcomes that we have presented in this chapter. Acceptability can be measured at the individual or community level through quantitative surveys that assess satisfaction. It can also be measured through qualitative interviews, including in-depth interviews or focus groups that explore participants' satisfaction with a particular intervention. And finally, acceptability can be measured through administrative data that collects data on service utilization over time. Adoption can be measured at the individual, community, or organization level, since the intention to try a new intervention can be an individual, community, and/or organization level decision. For example, the decision to integrate mental health services at a primary healthcare system can be made at the organizational level by clinic leadership, but the decision to utilize these services may be made at an individual and/or community level. Adoption can be seen through observation through a survey or through other qualitative data, such as in-depth interviews or focus groups, and through administrative data. For example, you can examine clinical records to check if primary care physicians are appropriately screening for and referring to mental health services. Appropriateness or fit of the evidence-based program or implementation strategy can also be measured through individual, community, and organizational level, through either surveys or qualitative methods. And feasibility, the extent to which an intervention can be carried out in a specific setting or organization, can be measured at the individual, community, or organizational levels through surveys, administrative data, and qualitative methods. Continuing on to the last four implementation outcomes, fidelity, the degree to which an intervention was implemented as planned, can be measured at the individual level through survey, observation, checklists, self-report, and administrative data. For example, if assessing the fidelity of a counseling session as an intervention, an independent observer could sit in on the session and complete a checklist to ensure that the session was delivered as planned. Implementation cost can be measured by the individual or organization level by assessing cost data that's already being collected by the clinic or organization. Penetration, the extent to which a population eligible to receive an intervention actually receives that intervention, can be measured at the individual, community, or organization level, also through surveys, checklists, and/or an audit by an independent observer. And finally, sustainability, which is defined as the extent to which an intervention is maintained in a given setting or context, can be measured at the individual, community, or organizational level using surveys, administrative data, and qualitative methods, including an audit. Let's now turn back to our 6 examples of studies of infectious diseases of poverty in the field. We can see how implementation research outcomes are measured both in terms of the multiple levels from which we draw our data from and the different methods used to collect these data. In Uganda and Cameroon, as you may remember, Katabawa and colleagues defined coverage as the total number of people treated with ivermectin among those who should have received it. They used both individual and community level data through community household treatment records that were completed by the community health workers. In the study, data on cost, which was defined as the cost of training, including allowances for the trainers, transport and food for trainees, and the training materials, was collected at the organizational level through the administrative system that already tracked these costs. In Nigeria, among nomadic Fulani communities who are managing malaria, coverage, defined, as you may remember, as the proportion of children under 5 who received anti-malarial treatment and the proportion of individuals under insecticide-treated nets, was measured at both the household and community level through household surveys. Acceptability, which was defined in the study as general satisfaction with a community-directed intervention strategy, and the 2 evidence-based interventions consisting of treated nets and malaria treatment, as well as the demand for the evidence-based interventions in the community, was assessed through qualitative in-depth interviews and focus groups at the individual level and feedback meetings at the community levels. These 2 studies are good examples of how one implementation outcome can be measured at multiple levels. You can see in the study by Akugan how if we want to get community-level perceptions of acceptability, a different data collection approach in the form of community meetings is used compared to the individual-level acceptability data collection methods. In our third example, in the study by Akawango and colleagues, as we remember, aimed to assess the impact of community medicine distributors trained to diagnose and treat malaria cases in children under 5 years of age using ACT. Fidelity was defined as treatment as planned, delivered by community medicine distributors, was measured both at the individual and organization levels using the records completed by the community medicine distributors. Coverage, defined in the study as a proportion of children under 5 who presented to community medicine distributors that were treated within 24 hours of onset, was measured at the household and the community level through a household survey completed by clients. Feasibility, defined here as the CMD's ability to recognize and promptly treat malaria cases and the caregiver satisfaction of these services, was collected at the individual and community level using qualitative interviews with caregivers. In our fourth example, Alke Brunar and colleagues assessed whether community-directed distributors' additional activities had a negative or positive effect on the distribution of ivermectin to treat onchocerciasis. Feasibility, operationalized here as attitude and performance of CDDs involved in other public health activities, was measured at the individual or CDD level through health worker survey. At the household level through household surveys, and at the community level through focus group discussions and in-depth interviews with caregivers. Coverage, defined as the proportion of the population who received ivermectin treatment in the communities from which the community-directed distributors were selected, was measured at the household level through household surveys. Moving on to our last two examples. As you recall, Sarima and colleagues evaluated the impact using prepackaged anti-malarial drugs by mothers at home on the progression of diseases in children from uncomplicated fever to severe malaria. Fidelity was the only implementation outcome assessed, and it was operationalized by looking at the proportion of children 6 years and under who had uncomplicated malaria that was treated as planned. Fidelity was measured at the household level through a household survey. And finally, Akugan and colleagues assessed a range of strategies for community-directed treatment of onchocerciasis with ivermectin in Nigeria. Fidelity, measured here as the appropriate adherence to the treatment regimen, correct dosage and frequency, and the correct management of adverse reactions to medication, was measured at the individual and household levels through a household survey. Coverage, defined in this study as the total number of people treated out of the total population after 2 cycles of treatment, was also measured at the individual and household level using a household survey. Feasibility, operationally defined in this study as acceptability of a range of community-directed ivermectin approaches and the cost and coverage under different approaches, was assessed at both the individual and household levels through the household survey, and at the community level using direct observations and in-depth interviews with clients. And finally, cost, operationally defined as all costs that the villages spend in delivering ivermectin, was obtained at the community level through a structured form that cataloged all inputs from the village. We can see from these examples that the levels from which we obtain data and the methods used for data collection stems from a combination of how we operationalized the implementation outcomes and what is realistically feasible given time and resource constraints. So we've learned in Chapter 3 how we operationalize implementation research outcomes and how we collect data on these outcomes, both in terms of sources and methods, using our 6 examples drawn from our required readings. Let's now revisit the statements that we used to gauge our knowledge about implementation outcomes at the beginning of this chapter. The first statement was, data for measuring implementation research outcomes are often collected across multiple socio-ecological levels. The correct response here is true. We know that data come from multiple levels, including patient, provider, clinic, facility, and organizational levels, to give us a fuller picture of the implementation effectiveness from multiple perspectives. The second statement, implementation research outcome data can be collected using both quantitative and qualitative methods. The correct response is true. We know that in order to glean a fuller picture of barriers to implementation and implementation effectiveness, it's necessary to use both quantitative and qualitative methods to understand the extent of barriers and effectiveness, and the hows and the whys behind those barriers, and to triangulate information from both sources and all methods. 3, administrative data are useful sources of information for measuring implementation research outcomes, such as cost and fidelity. The correct response here is true. To save resources and to avoid duplication, we can use already existing data that are being collected by clinics, programs, and organizations to assess implementation outcomes such as cost and fidelity. 4. Measurement of implementation research outcomes often involves scale development. The correct response to this statement is true. We know that often implementation outcomes are by nature latent variables. That is to say that these variables are not directly observable, but can rather be inferred from other variables that are observed. This may require scale development. For example, you cannot directly observe acceptability, but rather can combine a series of questions that together infer acceptability. This concludes Chapter 3 and our discussion on how to measure implementation research outcomes.